everyone, I'm so sorry. It seems like the recording did not work for this week, so I'm just going to do a brief recording here so that no one misses out on anything. So we started with questions. If you didn't fill it out last week, there's this QR code for the Get to Know You form. That's just a chance for me to get to know you, hear what you guys are wanting to do after your degree, learn what kind of teaching techniques work best for you so that we can try and make this the best experience for everyone. It is absolutely optional. Alrighty, so this week you learned about fixation techniques, and then we looked at the integumentary system and the skeletal system along with the pathologies that go along with them. And I just thought in terms of like the fixation process, and basically everything that happens before you have your tissue on a slide in front of you under the microscope, I thought I'd just kind of go through some of that process using examples from my own work and mistakes that I've made to try and make it a little bit more real for you. So starting with the question, how do we go from this? So how do we go from having, in my case, like an experimental animal tissue, or it could be a patient tissue, to this, to having beautiful images that we can look at under the microscope, either for research or diagnostic purposes? Well, the answer is tissue processing. But tissue processing is not as simple as I thought before I started working in this area. I had no idea how long of a process it was. So basically, we're just going to step through what it looks like from when you take your sample, walking through fixation, dehydration, clearing, infiltration to embedding. So you'll start by taking your sample. So for example, when I would go to do experiments, we would take containers for every single tissue, every single organ that you're going to take, and you go prepared with a fixative that's specific to the tissue sample that you're looking at. So we'll talk about this in a minute, but commonly fixatives are going to be things like formalin, they're going to be paraformaldehyde. I used methicon a lot, but sometimes it can just be 70% ethanol, depending on what you're basically going to be wanting to do. So with that, what you're going to do is basically you'll have all of your fixative solutions ready to put your samples straight into as soon as you take them, either from the patient or from the experimental animal. And the reason that we fix tissues is to basically freeze everything in time. So if you, it depends on the organ, but different organs are going to deteriorate at different rates. The pancreas, I believe, is the fastest to deteriorate. So if someone dies within about half an hour, the pancreas is already starting to basically degrade itself because it has so many potent enzymes within lysozymes that basically just all burst and then degrade the tissue. But different tissues are going to degrade at different rates. And the fixative's goal is to cross-link the proteins within the tissue, essentially freezing that tissue in time, so that enzymes and ultimately microbes don't degrade the sample. And this is really, really effective. So I think that formalin is just formaldehyde in water. Formalin, I believe, was discovered in the 1850s, and shortly after there were tissues that were fixed in formalin that are preserved enough that they're still intact enough to be looked at and sectioned and stained today, which is pretty amazing. Another like more popular example would be the doctor, I think it was like Dr. Harvey or someone, who was doing the autopsy after Einstein's death, had the foresight to preserve his brain in formalin, and that I think it's now all been sectioned out, but until very recently that preservation was good enough that it could still be sectioned and sent out to different places. Okay, so fixation is kind of freezing it in time, and then as soon as we've fixed it, the next step is dehydration. But why do we dehydrate? The reason that we dehydrate is basically to pull all of the water out of the tissue. So if you think about it, your alcohols are going to go in there, and depending on the strength of the alcohol, they're going to be able to basically pull the water out to varying degrees. And these are just funny photos of I found when I was trying to prepare for this, of one time in the lab. I forgot to check that our lab had enough supplies of alcohol before I did my experiment, and it was like a Sunday morning, early on a Sunday morning, and we had run out of enough alcohol, so I was having to run around to all of the other labs and raid their cupboards and text people and be like, I'm so sorry, but can I please borrow some of your alcohol, because in that dehydration step you're going to do multiple washes of the alcohol to try and pull all of the water out of it. And so you need quite a lot if you're working with a large number of tissues. So that was an embarrassing moment for me. After you've dehydrated your tissues with increasing strength of alcohol, then you're going to want to clear the tissues of the dehydrating agent. So an example that I often have used for that is xylenes, but there are different clearing agents to remove the dehydrating solution. And that the reason that we do that is because we basically want to empty it out of those dehydrating solutions before we put it into the infiltrating medium. And a lot of times the infiltrating medium, at least the one that I've used, is paraffin wax. And so basically the paraffin wax won't be able to get in there if it's still full of the alcohol. One last step on talking about like the various steps for the dehydration. One way that I like to think about it is if you spill water on your kitchen floor, like I do more than I would like to admit, you can use different things to soak up all of that water. So initially, if you have a lot of water on the floor, you initially might just throw a towel over it, and that kind of gets rid of a lot of the water, but it's still going to be a little bit slippery, right? So then you might use like a microfiber towel, and then you might ultimately at the very end use paper towel to really get the floor dry. And basically the different alcohols at the different strengths kind of achieve that same thing based on their polarity. So you can use different strengths of alcohol to just like really pull all of the water out of it. Yeah. Okay. So then you have your clearing. Yeah, and then your infiltration. So oopsies, sorry. Oh, I can't go back with this type of recording. Sorry. Okay. Oh well. We'll just keep on moving. So just a few key points with tissue processing. So yeah, histological specimens, as you've seen by this process, require extensive processing. Typically, we fix them in formalin, but as I mentioned, there's a number of other fixatives. And then you may require further dissection in the lab after fixing. So that's quite common. It's like you'll take your sample, you'll take your tissue, for example, from an experimental animal, and you'll dump it straight in the fixative, and then it's not until later that you're going to section it slightly more before you'll put it into the cassette, and then get it ready for embedding. So as I said, the three main steps are dehydration, clearing, and infiltration. The dehydration is getting rid of the water that's naturally in the tissue. The clearing is then getting rid of the dehydrating solutions, and then finally infiltrating it with the paraffin wax. It is what enables us to then be able to cut it up later. So in terms of embedding, you've got to be really careful how you orientate it within the paraffin wax. We'll talk about that more in just a second, because you want to have it correctly aligned for sectioning. You have to wait and allow the wax to solidify. Oftentimes, when you actually go to like cut it on the microtome, then you'll cool it down right before cutting it, just so that it is as solid as possible to get a really nice cut. And then, of course, you're always remembering to label your blocks. Label as you go through this process. So here I just had a few examples talking about orientation for embedding. So here we have a cylindrical lumen. Could be the esophagus, it could be anything really. But in terms of thinking about what orientation we would want it in for embedding, what do you think would be best? The answer is going to be this middle one here. We're going to want to orientate it so that we're able to see basically the epithelium around the lumen and then see what's right up against the lumen. So this is a skin biopsy, and we've got the epidermis at the top here, and going downwards, and we're going to want to be able to do it at a slight angle and go from the softer side to the firmer side. So in this case, this middle one is going to be the best orientation. Here we have a liver sample, and this white here is actually a tumor. And we're going to want to work through this sample from the narrowest side going wider. So in this case, this middle one would be the best orientation. And then here, if you've got multiple samples here, we have the epidermis going from on the left to the hypodermis on the right. And again, we're going to want to be able to get it at an angle. And so going from the softer side to the denser side, we're going to choose this as the best orientation. And then for this one, we've got the mucosa here going towards the serosa. And again, we're going to want to have it at an angle going softer to firmer. And so this one is probably going to be our best bet. All right, we did do a Kahoot in the class. I think the best way to do that is I'll upload the link for you guys to do it in your own time. And then I'm also going to upload some slice links for you to be able to see different, to be able to have a look at different histology images. Okay, and then we went through a few case studies. So let's see how we want to do this. This is a case study on Marfan syndrome. So I might just run through it quickly. So Marfan syndrome is a connective tissue dysfunction. And this is an example of someone called Javier, who is a 46-year-old male with a history of joint pain, chest pain, and shortness of breath. He also reports frequent eye problems. He has tall and slender body with long arms and legs, arachnodactyly, which means spider-like fingers, pectus excavatum, that means sunken chest, and he has a family history of aortic aneurysms. Physical examination reveals a systolic murmur, and he has a high arched palate and scoliosis. In terms of clinical history and diagnosis, James's medical history reveals a diagnosis of Marfan syndrome, a disorder of connective tissue that affects various organs and tissues. He is suspected to have connective tissue disorders affecting his cardiovascular, skeletal, and ocular systems. Echocardiography confirms the presence of aortic root dilation and mitral valve prolapse. Ophthalmologic examination reveals ectopia lentis, that means dislocated lens. Just a trigger warning, I have an image of that in just a minute that's a little distressing to look at, and myopia. Radiographic examination shows skeletal abnormalities such as increased arm span, reduced upper to lower segment ratio, and joint hypermobility. So in Marfan syndrome, we have, you can see there's a number of things affected. So basically, it's an autosomal dominant connective tissue disorder arising from a mutation in the FBN1 gene on chromosome 15. And that gene encodes fibrillin 1, which is a critical component of the microfibrils within the extracellular matrix. And these microfibrils provide structural support and serve as a scaffold for deposition of elastic fibers. So having those elastic fibers damaged basically leads to defective elastin deposition or fragmentation of the existing of any elastin fibers that are there due to the lack of microfibrillar scaffolds, which is very unfortunate. Okie dokie. So we're going to look at the dermis more. Well, no, we looked at the dermis this week. So, one thing that the disrupted microfibril formation and elastinopathy can lead to is the development of striae, which are stretch marks. So oftentimes you'll see this kind of presentation on someone's back. And then, unfortunately, the most serious effects of Marfan's are the cardiopathies. And so basically the weakened aortic wall in Marfan syndrome is susceptible to cystic medial necrosis, which is where the tunica media degenerates and weakens, and basically weakens the entire aorta, making it really prone to dilation, and can lead to the risk of aneurysms. Yeah. So then, like with many connective tissue disorders, it doesn't just affect a couple of parts of the body. We have connective tissue everywhere, so it affects a number of systems, including the eyes. So you'll often see ocular manifestations, like I mentioned, the retina, the lens, and retinal detachment and dislocation. So this was the image that I was warning you about. And then one of the things that's perhaps most obvious to other people, but I think not necessarily the most bothersome for the actual patient themselves, is just the physical manifestations. So they'll tend to have it's called marfanoid habitus, and it's basically like excessive growth in the long bones, which leads to being really tall with limbs that are really long. And then you also have the arachnodactyly, which is like the spider fingers that we mentioned, the pectus excavatum, which is the chest kind of caving in, and scoliosis. Okay, so that's that case study. We'll just go through this one as well, and then I might wrap it up. But this is a case study where you're not given it doesn't have the name of the disorder yet, so we'll just read through it and see at what point you start to have thoughts about what it could be. So we have Franklin, a 4-year-old boy who's brought to the pediatrician's office by his mother with complaints of clumsiness, weakness, and difficulty climbing stairs. Upon physical examination, the pediatrician observes that the boy has a waddling gait and struggles to stand up from a sitting position. His muscle strength is found to be decreased, particularly in the hips and thighs. The clinical history and diagnosis is that Franklin has been experiencing these symptoms for the last few months, and they seem to be getting worse. The mother also mentions that her mother had an uncle who died when he was 17 and was in a wheelchair in a few pictures she had seen. So they do further clinical investigation. They do genetic testing, muscle biopsy, creatine kinase levels, electromyography, and ultrasound, MRI, and CT imaging. So we looked at the differences between these two images. So you can see here in the healthy tissue, the muscle fibers are more or less uniform in their size and morphology. And you can also see that, as expected, the nuclei are peripherally located, right? But when we look over here at Franklin's biopsy, the muscle fibers are not uniform in size. You see how it's kind of like some really big ones here and then some smaller ones here. It seems like there's an attempt at regeneration. And the other thing is, like, there's this connective tissue that's kind of all around, and we have abnormally placed nuclei, like right here in the center. So this is just a little bit of a summary of those things. So in the normal muscle, the fibers are going to be long and cylindrical, but with Franklin, we saw that characteristic pattern of muscle fiber degeneration and regeneration. So some of the muscle fibers appear atrophied or necrotic, while others display signs of regeneration. And then in terms of the fiber size, for the normal healthy tissue, we saw that the fibers were relatively uniform in size, right? Minimal variation. Whereas for Franklin, there was a lot of variation in the size of the muscle fibers. And there's large hypertrophic muscles and small atrophic fibers. The nuclei in the healthy tissue is evenly distributed and peripherally located, which is exactly what we would expect. And then for Franklin, we saw the abnormal distribution of the nuclei. Some of them were just right in the center of the and scattered throughout the cytoplasm. And then for the connective tissue, it was minimal, and it was mainly surrounding the actual muscle fibers and the blood vessels, whereas for Franklin, the fibrotic tissue is replacing the degenerated muscle fibers, leading to muscle fibrosis and loss of normal architecture. And there's an infiltration of adipose tissue. And then finally, you don't expect to see much inflammation in normal muscle tissue, but for someone like Franklin, there is. And so the diagnosis, if you haven't guessed yet, is Duchenne muscular dystrophy. So that's an X-linked mutation, and it's going to lead to degenerated muscle fibers, infiltration of fibrous connective tissue, and central nuclei like we just saw. You're also going to be able to detect it with a creatine kinase result, and yeah, have abnormal imaging. So what is the pathology of Duchenne's? It's basically either the absence or deficiency of dystrophin protein, which is a protein that's associated with the muscle cell membrane. And if you have a weaker membrane, basically you're not going to be able to sustain muscle contractions without damaging the muscle itself. And that damage is going to lead to inflammation. You're going to have progressive degeneration. Those degenerated cells are going to try and regenerate, and that's where you're going to see the characteristic like forming, like the degeneration and reformation. Okay, so moving on to our next case study. Now we have a case study about a young 7-year-old girl, Beatrice, and she's small for her age, but the first thing people notice when they meet Beatrice is that her sclera are distinctly blue. So remember, that's the part that you normally expect to be white around the eye. It's blue. She's not an overly clumsy child, but she has a history of several fractures from minor injuries. Is this ringing any bells yet? These injuries always seem to heal quite slowly. So what would we expect to see for someone like Beatrice? Okay, well, first of all, let's start with the normal structures. So in bone, the normal structures that we have the Haversian canal, the Haversian system. So this entire structure here is the osteon, the Haversian system. And then it's going to be made up of a central canal surrounded by concentric rings of calcified matrix, which are called lamellae. So you can think of them like, imagine like the concentric rings that show aging in a tree, but just in the bone. And they are interspersed with these little black dots that are called lacunae. Lacunae is Latin for little lakes. So you're thinking of looking for just these little black lakes. And obviously all of that's surrounding our central Haversian canal that's containing our blood vessels and nerves. Okay, so then moving on to someone like the imaging that we would see for someone like Beatrice, you can see these two images here that the green is showing the mineralized tissue and the pink is showing the organic tissue. And I want you to think of bone like reinforced concrete. So if that's the case, you're going to have your collagen be what's providing basically the steel bars that are like having the concrete poured into, and the minerals are going to be like the actual concrete that's being poured into. So for someone like Beatrice, who unfortunately we're going to find out she has brittle bones, she has osteogenesis imperfecta. That's a disorder where you basically have the type 1, I believe it's type 1 collagen doesn't properly form. And so basically you're not going to have enough of those steel bars, in our analogy, reinforcing the concrete. And that's going to lead to a lot of brittleness in bones. But as we saw in our example, bones are not the only thing it affects, right? So we said that one of the first things that people notice when they meet her is the blue around her eyes, and that's because collagen is responsible for making up that sclera. Unfortunately, for patients like Beatrice, you're going to see a number of other things as well. So collagen is absolutely everywhere in our body, so it even affects things like hearing, because the bones in the ears are affected. Your conductive hearing is also affected. So for a lot of these connective tissue disorders, you might first notice it by like the gross appearance, like we said with Marfan's, but actually there are going to be a number of things that affect the quality of life of the patient that are much more unseen. Okay, so like our last case study we'll look at is asthma. So we have Sarah, a 5-year-old girl, presents with a history of recurrent wheezing, chest tightness, and shortness of breath. She experiences these symptoms primarily during exercise and exposure to animal fur and pollen. Sarah has a family history of asthma and allergies. Physical examination reveals expiratory wheezing and prolonged expiration. Sarah's medical history reveals a diagnosis of atopic dermatitis and recurrent respiratory infections. Based on her symptoms and clinical patient presentation, Sarah is diagnosed with asthma. Pulmonary function tests demonstrate airflow limitation, hyperresponsiveness, and reversible airway obstruction following bronchodilator administration. So what is the pathophysiology? Basically, we're going to see a complex mix of things that lead to this, which is it's going to be a complex mix of genetic predisposition, environmental factors, and immune dysregulation. But what's actually happening is the epithelial tissues are being significantly disrupted. And that's happening by barrier dysfunction, altered mucus production, dysregulated ciliary function, and enhanced inflammatory response. And we're going to walk through each one of those in terms of what it looks like. So the upper respiratory epithelium, it's specialized epithelial tissue that's ciliated pseudostratified columnar epithelium. And it's interspersed with all of these mucin-producing goblet cells. So remember, mucin combines with water to create our mucus. And together they form the mucociliary escalator that serves to basically brush out irritants and pathogens. So let's have a look and compare two different epithelial images. So you can see that in the healthy tissue here on the left, well, you can't actually see it very well, but I'm telling you, it's more ciliated. Whereas here in this chronic asthmatic image, the cilia are damaged. You can also see in the asthmatic image that there's a lot of immune cell infiltration. And we can also see this really distinct basement membrane, whereas the basement membrane is like hard to visualize in the healthy tissue, whereas it's really, really thick here. And one of the reasons for this is just an attempt at regeneration of cells. So there's a lot of hyperplasia of basically everything. We also have disrupted barrier function. So basically the cell junctions are there to, the tight junctions that are aiming to not let anything through. But when they're disrupted, basically we're going to have a bunch of allergens and irritants and pathogens that are now able to penetrate that barrier. We're also going to have an excessive production of mucus, and that's because we have too many goblet cells. And that's going to lead to airway narrowing, which is going to make it much harder to breathe. So you're going to have that wheezing, you're going to have a lot more coughing, and you're going to have it be a lot harder just to breathe. Unfortunately, it's also a great habitat for bacterial growth, and just the excess mucus is going to make it harder for the cilia to function underneath the weight of the excess mucus. So how does this hypersecretion of mucus happen? It's because we have the inflammatory response of all these cytokines telling these goblet cells to increase their mucus secretion. So basically, it's one of these classic things of one thing just leads to another, which leads to another, and unfortunately not in a beneficial way. And so we have goblet cell hyperplasia. So we have a chronic change to the amount of mucus, and airway remodeling. Like I said, we also have dysregulated ciliary function, and that's because basically the cilia are trapped under this heavy layer of mucus. Yeah, that's what I was just saying. Yeah, so I think we will leave it there for today.